or true end arteries. But in case of coronary arteries, they are referred to as functional end arteries. So why is that? Because they are anatomically not end arteries, because they have collaterals, but the collaterals are very ineffective. Which means when there is a sudden obstruction in one coronary artery, all these collaterals do not open up suddenly and supply the artery. So they go for necrosis. So these coronary arteries are functional end arteries, and they are vasa vasorum of the ascending aorta. And now we'll see about the origin of these coronary arteries. Like you all know, there are two main coronary arteries. One is the right coronary artery and the other one is the left coronary artery. They arise from the sinuses of aorta. So sinuses are nothing but they are dilations. Okay, they are dilations in the wall of the aorta just above the aortic valve. Okay, so this is the cusps of the aortic valve, and between the wall of the aorta that you can see here and the cusps of the aortic valve, you have the dilations. So this thing is known as the aortic sinus. Okay, so there are three sinuses. The first one is the anterior aortic sinus, and you have two posterior sinuses, which is right posterior and left posterior aortic sinuses. So from the anterior sinus, you have the right coronary artery arising, and from the left posterior, you have the left coronary artery arising. And this is left out. The right posterior sinus is left out, and it does not give rise to any coronary artery, so it is also termed as non-coronary sinus. So this is the introduction about the coronary arterial circulation. Moving on to the course of the two coronary arteries. Before going to the course, I just want to tell you, brush up about the grooves of the heart so that you understand this better. Here you have the right atrium, and this portion is the right ventricle. So in between these two, where the right coronary artery goes this groove is known as the right anterior atrioventricular groove. And on the other side, you have the left anterior atrioventricular groove over here. And posteriorly, you have the right posterior atrioventricular groove over here, and you have the left posterior atrioventricular groove. And together, you can also call it as the posterior atrioventricular groove. And we're done with the atrium and the ventricle. And here you have the two ventricles that are separated by the posterior interventricular groove. And on the anterior side, you have the anterior interventricular groove, which separates the right and left ventricle. So this is about the grooves. Now I just want you to imagine a heart and then how the artery goes out. So it will be very easier for you to hold on to the next venous drainage part and the clinical application and all those. So firstly, coming to the right coronary artery, like we already saw, it starts from the anterior aortic sinus over here, and it runs in the right atrioventricular groove down till the border, where the right and the inferior borders of the heart meet. So till that thing, it descends vertically downwards, and then it takes a posterior turn and runs in the posterior atrioventricular groove. And it ends at the level of the posterior interventricular groove here by anastomosing with the left coronary artery. So this is the course of right coronary artery. Coming to the course of left coronary artery, it is similar, like it arises in between the pulmonary trunk and the left auricle, and at this level itself, it divides into two important branches. The first one is the LAD branch, which is left anterior descending branch, because it descends in the anterior interventricular groove. It is also known as left anterior interventricular artery. Okay, and there is this another small branch, which is the left circumflex artery. It takes a course similar to the right coronary artery. Okay, it originates over here and then it goes in the left atrioventricular groove anteriorly and posteriorly. Okay, this is the course of the right and left coronary arteries. Just remember this, so this will make the venous drainage part very simple for you. Moving to the branches of coronary artery. So I have just grouped them into four so that it's easier to understand. So we'll try to learn them by connecting, by seeing the similarities between the branches of the right and left coronary artery. So first we'll see about the conus arteries. Both the right and left coronary artery gives rise to the conus artery. So you have the right conus artery and the conus artery, which is a branch of left coronary artery. So these two have a very important function. They go and supply the pulmonary conus. So what pulmonary conus is nothing but it is a conical, a flask-like structure from where the pulmonary trunk arises. Okay, it is situated in the right ventricle because we know that the pulmonary trunk arises from the right ventricle. So that part is supplied by the right conus artery of both the sides. And moving on to the atrial branches, both the right and left coronary arteries give away atrial branches. Okay, they supply the respective atria. From the right coronary artery, it supplies the right atrium, wall of the right atrium, and the left coronary artery, it supplies the wall of the left atrium. Okay, we have the atrial branches. And moving on to the ventricular branches, in the right coronary artery, we have anterior, posterior ventricular branches, and similarly on the left side you have the diagonal artery which supplies most of the part of the left ventricle. So you can connect these two. In the right they are named as anterior and posterior ventricular branches, and from the left coronary artery it is diagonal artery. Okay, they both supply the ventricles. And moving on to the last one, posterior interventricular and LAD and circumflex, these are kind of special, so you will have to remember it separately. Okay, posterior interventricular artery is also, it is abbreviated as PDA artery. It is a very important artery, and it is one of the main branches of the right coronary artery. I'll show you. You can see the artery over here. So that artery is the one which anastomoses with the posterior interventricular artery, the LAD branch which goes posteriorly. And in the left coronary artery you have the LAD and circumflex arteries. So these two are the big main branches of the left coronary artery. So you can remember it as such. Okay, so LAD, you have the LAD over here and the circumflex over here. So this is about the branches. We saw the first one is the conus artery on both the sides and the atrial branches on both the sides, and the ventricular branches is just named differently. The diagonal artery does the same job, like it supplies the left ventricle most part, and the anterior and posterior ventricular branches, it supplies the right ventricle and the septal area also. And the posterior interventricular, yes. Okay, so posterior interventricular and the LAD and circumflex, that you will have to remember separately. Okay, so this is about the branches. Here I just want to tell you a few specific branches. Okay, in the right coronary artery, from the atrial branch, you have one important branch which is known as the SAN branch, sinoatrial nodal artery. So it supplies the sinoatrial node. And the posterior interventricular artery gives the branch to supply the AV node. Okay, that is also very important that you have to remember. And so that's it. And the posterior ventricular branch gives right marginal branch. So that is also important. And the circumflex artery gives the left marginal artery. Okay. So these are important just to understand the venous drainage part. So remembering this will do. Moving on to the two separate entities that I already told we'll be discussing about. The first one is coronary dominance. So coronary dominance is mainly said with respect to posterior descending artery. I already told you that PDA artery is very important. So this PDA artery, whichever artery gives the PDA artery, becomes the dominant one. So in this picture you can see that the right coronary artery gives rise to the posterior descending artery. So here it is said to have right coronary dominance. And in this picture you can see that the left coronary artery gives rise to the PDA branch. So this is known as the left coronary dominant circulation. Okay. So why is this important is that it has a clinical role in case of myocardial infarction. So in patients with the right coronary dominance, one more thing I want to tell you is right coronary dominance is very common. Okay, 90% of the individuals will have right coronary dominance, and only 10% of the individuals have left coronary dominance. So these individuals have an advantage in case of MI, because when the patient is right coronary dominant, the PD artery arises from the right coronary artery. Okay, so this artery, when it the LAD artery is most prone for atherosclerosis. So when the LAD artery is blocked, the inferior wall is supplied by the PD artery, and even the septal area is also supplied by the PD artery. So when LAD is blocked, this serves as the collateral circulation channel to maintain the blood flow until this blockade is taken out. Okay, but in case of left dominant people, the PD artery comes from the left coronary artery, and LAD is most prone for blockade. So when there is a blockade over here, there are no collateral channels to supply the inferior wall of the heart. So it leads to ST elevated myocardial infarction, or you can call it as inferior wall myocardial infarction. So this is about coronary dominance. Coming to coronary anastomosis, we have already kind of discussed this in the name of functional end arteries. Okay, so in functional end arteries, the collaterals will be ineffectively formed. So coronary artery is a very good example for ineffective collateral formation. So here the time factor is very, very important. Okay, so when the plaque starts forming very slowly, like over years, in case of old patients, they are very prone for atherosclerosis. Okay, so this plaque, it forms very slowly over time. So when it takes so much of time for the stenosis to totally obstruct the lumen, all these collateral channels will have a lot of time to open up and provide a proper collateral circulation. Okay, but when the plaque formation is very acute, when there is a thrombus suddenly occluding the vessel, there is no go, like the tissue completely goes for ischemia and necrosis, and myocardial infarction occurs. Okay, so this is about coronary anastomosis. We're coming to the near the end of the presentation. So this is the venous drainage. There are three main venous channels that drain the heart. The first very important one is the coronary sinus. You can see the huge, the big vessel that runs in the posterior side of the heart and drains into the right atrium. So this is the biggest venous channel in the heart, and it has a lot of tributaries adding up to it. And then the second one is the anterior cardiac veins, and the third one is Thebasian veins, which are very, very small. So first we'll see about the coronary sinus. Here I just want you to bring the arteries picture to remember the venous drainage better. Okay, I have just grouped all the cardiac veins and the marginal veins, and these two veins that you will have to remember separately. First, let's talk about the cardiac veins. We have three cardiac veins. Great, which is present in the leftmost area, and the middle one, which is in the middle, and the small one, which is in the rightmost area. Okay, you can remember it like that. And the great coronary, the great cardiac vein, it accompanies the two main branches of left coronary artery, that are LAD and LCX. Okay, it accompanies both these arteries and drains in the left end of coronary sinus. So this is the great cardiac vein. And the middle cardiac vein, it accompanies the posterior interventricular artery that we already saw, and it drains into the coronary sinus. And the small cardiac vein, it accompanies the right ventricular branch, and it also drains in the right end of the coronary sinus. This is about the cardiac veins. And marginal veins, I already told you there are two marginal arteries that supply the borders. The right marginal artery supplies the right border till the apex, and the left marginal artery, it supplies the left margin till the apex. Okay, so they kind of hold the heart in the apex. So these two veins accompany those arteries. Okay, it is very simple to remember. And coming to the posterior vein and oblique vein of LV and LA respectively, this posterior vein of left ventricle, like the name suggests, drains the left ventricle, mostly the sternocostal surface. And the oblique vein of left atrium, it supplies the left atrium, mostly the posterior part of the left atrium. So these are the main tributaries of the coronary sinus. All these add up to form this huge venous channel, which lies in the coronary sulcus, or you can call it as posterior atrioventricular sulcus, and it drains into the right atrium. So this is about the coronary sinus. And moving on to the anterior cardiac veins. So they are not very huge veins, they are very small. You can see them here. They are usually 3 to 4 in number, and one feature about them is they run parallel to each other, and they separately drain into the right atrium. Okay, this is about anterior cardiac veins. They mostly drain the right ventricle. Coming to Thebesian veins, or they are also known as venae chordae minimi. So these are very minute, tiny veins. Okay, so they are present all over in all the chambers, and they drain their blood into the respective chambers. And among the chambers, the right atrium has the highest number of Thebesian veins. So this is about the venous drainage. I hope it's clear. If you just go through it once again, it will be very easy for you to grasp it. Coming to the interesting part, so the heart should keep functioning so that the blood is given to all the parts of the body. Okay, so it has to work a lot. So the musculature has been specialized for that case, and this blood supply is very, very important to keep them going. So when there is even when there is a minute problem, when there is a little stenosis in these coronary arteries, it will be shown as the patient will be presenting with angina. So it is a very common term, like you might have already come across in your family, or mostly your relatives. Somebody will have this heart problem, angina, and nenguvali irukku அந்த மாதிரி. Okay. So angina pectoris is you can say a pressurizing, stabbing kind of pain, squeezing kind of pain in your thorax region, and it will usually last for about 15 to 20 minutes. And this pain, it comes only with exertion. So when at rest, the pain will not be there, okay, because the heart will be functioning normally, and the blood will go. Blood will reach the heart muscle, but when there is exertion, all the blood will be diverted to the muscle part. So heart will lack oxygen, and then due to ischemia, there will be pain. So the first one is the symptom of stenosis of any coronary artery is angina pectoris. And moving on to myocardial infarction, you can just say it is a higher level of angina pectoris. So when there is a complete blockade of an artery, like you can see here, there is a total blockade of this artery, and the area of heart which is supplied distal to the artery goes for ischemia and necrosis. So in this case, the pain will last for more than 30 minutes, and it will be more severe, of course, and the pain will also be referred to the left arm, medial side of the left arm, and sometimes forearm too, and it might also get referred to jaw. Okay, jaw and the left side of the face, it can also get referred there. So this is about myocardial infarction and angina pectoris. Okay, so we know that there is stenosis when you have angina, when you have chest pain. So you will have to confirm where the blockade is. For that, the procedure you use is coronary angiogram. Here, firstly, a dye will be injected intravenously. It is mostly gadolinium based dye or an iodine based dye. It will first be infused intravenously, and then when you picture the heart radiographically, you will be able to see the arteries this way. So wherever there is a blockade, you will be able to appreciate it in the coronary angiogram. And this picture represents coronary angioplasty. So now you know where the block is. So you will have to relieve it so to maintain the blood supply. So what they do is either through, they call it as the wrist route or the groin route. In the wrist route, they go through the radial artery, and in the groin route, they go through the femoral artery. So a catheter is introduced with the inflatable balloon at its tip. So once they reach the site of blockade, the balloon is inflated. Okay, so this pushes the plague over here, pushes the plague flat on the surface of the wall, and then a stent is placed. So this stent is usually made of medical grade steel, or nowadays they use chromium and cobalt alloy to make it, and the stent stays in there forever to maintain the dilation. So this is coronary angioplasty. In severe cases, when the blockade is very severe, they also opt for bypass graft. So this is the blocked artery. What you do is you take a graft. The main graft used is the great saphenous vein, because it is very easy to get also. Like it is very easy to dissect, and even when you take a considerable length of the vein, you will not have any valves in it. So it is easier for you to place it over here, and it is also nearly equal to the size of coronary arteries. So that graft is mostly taken, and one part of the graft is put over here in the ascending aorta, and the other end is put distal to the ascending aorta over here. Okay, so this is about the clinical. Okay, so this is about the applied anatomy. This is a very quick summary. We saw about in the introduction, we saw that the coronary artery is the vasovascular of the ascending aorta, and it is a functional end artery because it has the ineffective collateral channels. And we saw about the origin, codes, and branches of right and left coronary arteries. And we saw what is coronary dominance and coronary anastomosis. And then we ended the session with venous drainage and a few clinical applications, or you can say applied anatomy of the blood supply of heart. So that's it, and all the very best for your exams whenever they are about to happen. Thank you. Okay.